Now let's look at hyperthyroidism. What would we expect to see in a patient who is hyperthyroid? And by hyperthyroid, we mean they have an excess of T3 or T4. So in these patients, we would expect to see them have an increased metabolic activity. So as a result of this increased metabolism, they are generating more ATP, which is going to release heat. So they, on clinical exam, are going to tend to have warm, sweaty skin. These patients are going to experience weight loss because they are burning so many calories to try and keep up with this metabolic activity increase. Because of the increased beta-1 receptors on the cardiovascular system, we will see increased cardiac output because of the increased heart rate and increased contractility. We will see muscle breakdown. The beta-2 receptors on skeletal muscle increases proteolysis, so we can see these patients having weakness. We mentioned the effects of the thyroid hormone on the nervous system, and an excess of thyroid hormone essentially ramps up the activity of the nervous system, though these patients often are what we call hyperreflexic, meaning if you check their normal deep tendon reflexes, they tend to be exaggerated. Along these same lines with the nervous system, these patients are oftentimes irritable and have trouble sleeping. With regards to the GI tract, because of the increased levels of T3 and T4, these patients are going to have increased motility of their GI tract, which means increased bowel movements or perhaps even diarrhea. Now, a common cause of hyperthyroidism is this disease called Graves' disease. So here we have our hypothalamus and anterior pituitary. The anterior pituitary is typically releasing TSH, which will then bind to the TSH receptors on the thyroid, and that will in turn cause the creation of T3 and T4. Now, Graves' disease is a situation where this is an autoimmune disease, which means these patients, their own immune system creates antibodies that can bind and cause abnormalities. So in Graves' disease, they create an autoantibody that is specific for this TSH receptor. So when they have these autoantibodies present, these autoantibodies then will bind to the TSH receptor. So this is in essence mimicking the actions of TSH. The receptor is not telling the difference between normal TSH and the autoantibody, and so it simply responds as though TSH is stimulating it, and because of these excess TSH receptor autoantibodies, it's going to cause an increase in thyroid function. So we'll see an increase in the thyroid hormone production. Now this is where we need to see what's the impact with regards to feedback mechanisms. Well, in this case, because of the increased T3, T4, this is going to feed back, and we'll see that there'll be a decrease in TSH. Now this decrease in TSH doesn't cause any reduction in T3, T4 because this is being driven by these autoantibodies being present. So these patients with Graves' disease are hyperthyroid. And because that TSH receptor is being stimulated, again, it's going to be mimicking the actions of TSH. So TSH is a trophic hormone, so the actions of it binding to the receptor on the thyroid are trophic. So patients with Graves' disease will tend to experience enlargement of their thyroid or experience goiter. Now these are pictures that show patients with full-blown Graves' disease. So you can kind of get a sense, if we talked about the symptoms of hyperthyroidism, we said that these patients oftentimes have an increased metabolic rate, which causes them to lose weight. So notice that both of these patients seem to be somewhat on the thin side, perhaps appear a bit irritable as a result of the nervous system effects. But the striking findings here are twofold. One is, notice the neck here. This is the enlarged thyroid. So this is a thyroid goiter. And then most obvious is these eye findings. So what happens in Graves' disease is they have a deposition of a substance into the muscles that surround the eye. And that causes an increase in volume of the material within the orbit, and that causes the eye then to protrude forward. So we call that exophthalmos or proptosis. So the name for this is called Graves' ophthalmopathy, and it's also referred to as thyroid eye disease. But this is a situation we refer to this as a pathognomonic finding, and that is that if we see this, we know clinically that this patient has Graves' disease. Now there's other potential causes of hyperthyroidism as well, and one could be a hyperfunctioning thyroid nodule. So imagine in this situation we have a normal thyroid gland, and here we have what we call a radioactive iodine scan. And this is a scan which is shows us the anatomy of the thyroid gland, because the thyroid is the only part of the body that uses this chemical. So this is a normal scan. In a patient that has a hyperfunctioning nodule, think of this as being just some cells here that have gone haywire. They've developed a mind of their own. They are what we call autonomously functioning. So they are going to be pumping out excess T3, T4. Not because of any stimulation of TSH, but just because these cells have got some loose wires. So as a result of this increased T3, T4, it is going to feed back and cause a decrease in TSH. Even though the TSH is decreased, the T3 and T4 are elevated because of this autonomously functioning nodule. Now the benefit of the scan is that in a patient that has this hyperfunctioning nodule, what we can do is do the same scan, and we'll see that this area of the thyroid lights up. This is what we call a hot nodule because of the hyperactivity of this nodule taking up this excess iodine. We may also see hyperthyroidism as a result of a hyperfunctioning nodule within the anterior pituitary. So in this case, we have a autonomously functioning nodule pumping out excess levels of TSH. As a result, that's going to cause the thyroid gland to increase its output of T3 and T4. In this case, the T3 and T4 again will try and feed back and inhibit TSH. However, because this is autonomously functioning, it's not going to respond to these feedback mechanisms, and we'll continue to see the excessive production of T3, T4. Now in this situation, we will have hyperthyroidism, and we again will also experience a goiter because the TSH is a trophic hormone, and it will cause general enlargement of the target tissue, the thyroid gland. So there are various causes of hyperthyroidism. We are not covering all of them, but just listing a few. Graves' disease is a very common cause of hyperthyroidism, and in this case, the T3 and T4 are elevated and the TSH is decreased. A toxic thyroid adenoma or a hyperfunctioning nodule, T3, T4 increased and TSH is also decreased. A pituitary adenoma. In this case, the T3 and T4 are increased, but TSH is increased. Okay. So notice that we're going to see differences in the TSH, but that can perhaps help direct us to our workup to determine where the problem is with the patient who presents with hyperthyroidism. And then finally, there's another cause of hyperthyroidism, and this is called thyroiditis. This is just an inflammatory condition of the thyroid which causes it to leak excess T3, T4. So they are hyperthyroid, but their TSH is decreased. So realize by just looking at what we see here on the slide, if a patient comes in and are hyperthyroid, just on clinical exam, if we do standard blood tests looking at T3, T4, we expect that to be elevated in all these situations. But in this case, if the TSH is elevated, then we know that we need to focus our attention on looking at the pituitary. If the TSH, however, is decreased, then we don't need to spend time or the resources of obtaining an MRI looking at the pituitary gland. We need to evaluate for other causes that may cause hyperthyroidism. We can check levels of autoantibodies, and if those come back positive, then we know we have Graves' disease. We could do a thyroid iodine scan looking for a hot nodule to see if that is something that's the source of the hyperthyroidism. There are other blood tests that we can do to assess for thyroiditis. So it's important to understand the feedback mechanisms because that can help us direct our path to evaluate for the underlying etiology of their illness.